Okay, so there are some disorders from the infectious diseases background that will cause some abnormalities in the cell count in the CBC, and that's what we're going to go through this presentation. I will start by saying that um, based on a case study of a very young man, college student, with no important past medical history, but he did complain about a progressive fatigue, sore throat, and fever. And fatigue, sore throat, and fever can be a triad, um, also accompanied by myalgia. And in this case, this patient was presenting also a very not common complication with the presence of dark color urine. Um, you at this moment might be thinking that exactly those are very good positive pertinent for this case. The presence of myalgia, malaise, and dark color urine maybe won't match, but with the flu-like symptoms, but fatigue, sore throat, fevers do. He also noted mild upper quadrant discomfort, which is referring to liver pain, and also yellowing of the eyes over the past 2 days. What causes the eyes to be yellow? Well, the elevation of bilirubin. So it seems it has a problem in his liver, not only due to the yellowing of the eyes, of the conjunctiva, which is called icteria, but also by the dark color of the urine can be also produced by elevation of bilirubin. Uh, One negative pertinent, very important when you're suspecting a problem in the liver is to ask about alcohol use or abuse. And also the use of any medications that are known by its detrimental effect over the liver, like, for example, the acetaminophen or painkillers. Also, recent travels, because maybe the close contact with a patient with hepatitis A, drinking water contaminated with hepatitis B, or being in contact with other people that has hepatitis. So, of course, if we're suspecting here in this very young uh, patient that is having a lot of symptoms that are related with flu-like symptoms, but also in additional symptoms that has to do with liver dysfunction. Let's go to the physical examination. We have a patient that has a 38.5, not quietly fever, but what we call febricula, little fever, a little bit of tachycardia, 98. Um, Blood pressure is okay, respiratory is okay, and oxygen saturation is okay. In general, he appears alert, but fatigued and mildly icteric. Pharyngeal erythema, but no exudates. That's important. So that will make like differential diagnosis with strep or other viral infections in the pharynx. And we are seeing icterus present in the conjunctiva. Um, in the neck, we do have posterior cervical lymphadenopathy. So this is another thing. It means like, oh, it looks like a viral infection. Probably we have pharyngeal erythema, we have lymphadenopathy in the posterior cervical lines, and we should examine all the time, especially because we have pain, but also we have icteria, And every time that you have flu-like symptoms, please go ahead and examine the abdomen. We look to the quadrants, and there is tenderness in the right upper quadrant that corresponds to the liver with a little bit of hepatomegaly, but no rebound or guarding. In the skins, apart from the icteria of the conjunctiva, there's no rash and petechia, and the neurological exam that we should also do, and it's normal. Patient is oriented, so we don't have more compromise there. Past medical history, no chronic illness. He is fully vaccinated, thinking about hepatitis B, no drugs, allergies in this case, and he is a sophomore in a college. He lives with other students, so that is important. It's a possibly pertinent. We should ask if somebody else had the same symptoms. He denies substance abuse. He's sexually active with one partner and no recent travels, and it seems like he had no sick contacts. Here is our patient. What are my positive pertinent? Well, we do have a little bit of tachycardia. Patient is fatigue, mildly ecteric, pharyngeal erythema without exudates but sclera icteris present, bilateral posterior cervical lymphadenopathy, mild right upper quadrant tenderness with hepatomegaly, and no rash or petechia. So when we have a college student that presents fever, sore throat, and fatigue, those are very characteristic for flu-like symptoms. Uh, Specifically, we need to rule out as first differential diagnosis infectious mononucleosis. There are other differential diagnoses like strep, uh, sore throat due to streptococcus, or any other flu-like symptoms that can be due by the flu, influenza, influenza virus, or COVID-19 virus, the SARS-CoV-2 virus. So there are key mimickers to understand conditions that present very similar symptoms to infectious mononucleosis. Let's try to go and review about some of the features of infectious mononucleosis that are present in younger and older groups. And mainly, we can divide infectious mononucleosis in two types. The glandular one type that usually is present in patients less than 35 years old, young patients, or the systemic type of infectious pneumococcosis that usually it's presented by patients more over 40 years. So lymphadenopathy, the glandular type, will be characterized by pharyngitis, lymphadenopathy, fever, uh, and it can have a splenomegaly, sometimes hepatomegaly. On the case of the systemic one, the main one of the main symptoms is going to be fever. Okay, also lymphadenopathy, pharyngitis, and hepatomegaly. Either way, uh, both types of patients can present rash, can present icteries or jaundice, um, and uh, splenomegaly can be involved. Now, cytomegalovirus infection has very similar symptoms, malaise, flu-like symptoms, um, but it will have a negative monospot, and it will have a positive IgM for cytomegalovirus. The acute presentation of an recent HIV patient will have fever, sore throat, and it will have rash. Of course, the distinguished factors are going to be due to the risk factors, in this case, non-protected sex, or the patient has received um, blood or is a drug abuse, IV drug abuse, or any other risk factors related with HIV transmission. And of course, it will have an RNA HIV test positive. Streptococcal pharyngitis will have sore throat and fever, but it won't have in the CDC a lymphocytosis. Usually, it will have neutrophilia and it will have a positive strep test. Toxoplasmosis, it will be characterized by lymphadenopathy and also contact with little cats and a toxo IgM antibody test positive. Acute leukemia, it is characterized by fatigue and lymphadenopathy, and this is one of the differential diagnosis we need to take into account. But remember, in acute leukemia, we also have pancytopenia, presence of blast from the smear blood test. Lymphoma, persistent lymphadenopathy. Also, we can have biopsy and imaging in order to discard if this is a malignant process. The monotriad usually is going to be fever, pharyngitis, and lymphadenopathy. But that is present in other etiologies, like not only for Epstein-Barr, which is the virus that causes infectious mononucleosis, is also present in cytomegalovirus and in other viruses. Other signs are going to be hepatomegaly, splenomegaly, or both, fatigue, and sometimes rash, especially if you indicate amoxicillin to those patients. Okay, patients are going to have low-grade fever, headache, malaise, in the throat, tonsillitis or pharyngitis with no exudate, even though cervical lymph nodes can be enlarged and tenderness. There is sometimes the exudate in the tonsillar can be gray, green, white, or necrotic appearance. Patients will have a splenomegaly in 50%. That's why we need to prevent um, spleen rupture and indicate to the patient not to do sports that can hit their abdomen. The presence of jaundice and hepatomegaly, it is considered a rare complication. Most patients will have, if they're younger, the glandular form of the disease, as I told you, characterized by lymph node enlargement and pharyngeal symptoms. Systemic form of the infection will be characterized by fatigue and fever, which are systemic symptoms. Also, they can have lymphadenopathy or pharyngitis, mild or absent. Some patients will have hepatitis symptoms, and the acute symptoms for infectious mononucleosis will resolve usually in 2 weeks, but the fatigue can persist through several months. So the way the infection starts, we have the virus entry through the cells, epithelial cells and B lymphocytes. It replicates. We have recognition of the T cells by infected B cells, and then after the process is done, the virus will stay in lifelong as a latent infection. Here on this graphic, you can see the frequency and percentage of each one of the symptoms, meaning malaise and fatigue is a very important one. Sweats, sore throat, dysphagia, anorexia, nausea, headache, chills, cough, and less common, ocular muscle pain, chest pain, arthralgia, and photophobia. Some of the signs that are important: adenopathy, fever, pharyngitis, splenomegaly, bradycardia, and the other ones are less. Sometimes liver and spleen tenderness, palatal and a thin periorbital edema. Okay, in our case, this is a very young 18, 19-year-old male student, so we are going to expect that he will present symptoms due to the glandular part of the disease, which is going to be characterized by pharyngitis and lymphadenopathy. But he is developing dark urine, right upper quadrant discomfort, and yellowing of the eyes. So he's having jaundice. He has progressed about 10 days with fatigue, sore throat, and fevers, and he denies any risk factors for problems in his liver. When we go to the labs, we see that the white blood cell count is 4,000, which is seems a little bit low. Lymphocytes are present, and 60% of those lymphocytes are atypical form, and that is a clue that is very important. Hemoglobin and plaquettes are normal, so we discard any lymphoma. Also, we see that the liver function are both enzymes AST and ALT, aspartato and aniline transferase. Both transferases are high, they should be around 30. Both of them are high, and also total bilirubin is high. That's why we're presenting jaundice. When we do diagnostic tests that should include liver enzymes, CBC, and also special diagnostic tests like hepatitis panel is going to be negative, but monospot test for Epstein-Barr is going to be positive. The darker urine has elevated urobilinogen, and that's what correlates when we have elevated bilirubin, it will be excreted through the urine in the form of urobilinogen, and that's why this patient is presenting dark urines. These are the typical lymphocytes characterized in infectious mononucleosis, and we usually see them in a peripheral blood test. We have lymphocytosis and atypical lymphocytes. Typical for infectious mononucleosis. Also, we can have manifestations in the tongue or oral hairy leukoplakia, and it is associated with high replication of the Epstein-Barr, and also we can see this especially in immunocompromised patients. Also, rash in infectious mononucleosis, it's characterized by erythematous maculopapular eruption. Sometimes it may be seen in patients after we administrate amoxicillin or ampicillin. This should be not done in patients that has a viral infections. We should not give antibiotics. The Epstein-Barr uh, can persist asymptomatically after an infection for life, and it has been associated with B-cell lymphomas, Hodgkin's lymphoma, and nasopharyngeal carcinoma. Also, it has been related with long COVID symptoms. And remember that it is the primary agent of infection mononucleosis, but it also, because of its long persistence, can develop in other disorders. Epstein-Barr has tropism for several immune cells, like B lymphocytes that are the primary reservoir, and T lymphocytes are secondary host cells reservoir. It can infect in natural killer cells. It can replicate in epithelial cells, and is unlike herpes simplex virus or cytomegalovirus, Epstein-Barr virus can transform B cells uh, into malignant cells. How do we do the diagnosis? Well, we usually use in our mm, private location a test that's called monopost, and it's an heterophile antibody test, even though it's not such specific as a specific serology like IgM. It will give us a rapid result. Also, we can ask for a CBC and for the study of the smell to look for atypical lymphocytes. So the lab studies will include um, to check the CBC in patients. Leukocytosis can be developed on the second or third week of illness, and usually it goes up to 10 to 20,000. We can have leukopenia also. The presence, the important thing is to analyze the CBC in order to calculate if we have lymphocytosis, which is more than 50% of all the white cell count, and also atypical lymphocytes would be more than 10%. And also an absolute lymphocyte count greater than 4,000 also has a sensitivity of 0.97 and a specificity of 0.96. And a typical lymphocytosis more than 10% has a specificity of 0.92. The specificity increase with the increase of percent of atypical lymphocytes. So we should ask to look for typical lymphocytes in infectious mononucleosis. Other tests should include liver enzymes, as I told you before, bilirubin, also creatinine to verified kidney function, electrolytes, and also discard other viral tests like herpes virus, cytomegalovirus, and toxoplasmosis. Here we can see, starting with day 0 of the infection, the way that the heterophile antibodies in color gray, this one, will appear from the 4th week up to the 12th week. And in color blue, we can see the anti-VCA IgM, which is one of the most specific antibodies. And also we can see in color green the anti-EBNA, which is the nucleus IgG antibody, which is not specific, that will start around 6 weeks. And these are like the curves of, also we have here the DNA of Epstein-Barr from 4 weeks to 6 weeks, and the anti-IgG in color black, anti-VCA IgG. That will start on the 4th week and it will continue. This part of the chart is indicating cases of reactivation of Epstein-Barr, that it occurs usually in immunocompromised patients. So heterophile antibodies or monotests can also be used to diagnose, especially in settings where the pretest probability of infection is high or ABB antibodies are not available. The CDC recommends against using those monotests due to the lower sensitivity and specificity for immune infections in mononucleosis. But because it has a low cost and it's very easy to do, it is still used. The specific antibodies is to detect IgM positive for Epstein-Barr. VCA, EBV VCA suggests, if it's positive, acute infection. And If we have ABNA negative, it will confirm acute Epstein-Barr infection. The ABNA should be negative in acute infection, in recent infection, and VCA IgM should be positive in an acute infection. So here is the three types of antibodies that we have. We also have VCA IgG that is present on the onset of the illness, and it will be present lifelong after a positive infection. So if we have an IgE positive, we should do an ABNA, and if it's negative, this is where we have likely to have with symptoms Epstein-Barr infection. If we have a positive, um, maybe serology will suggest recent infection, but depending if the symptoms onset is less than 4 weeks, if it's yes, it will be unlikely to be caused by Epstein-Barr, but it has more than 4 weeks, it is potential caused by Epstein-Barr. The same thing if we have a negative IgM, but we have a positive IgG, and then a positive ABNA, it is unlikely to have Epstein-Barr. If we have a negative, it's a potential Epstein-Barr. Okay, it has to be, if we have a negative IgM and a positive IgG, a negative IgM with a negative IgG, it is unlikely to be Epstein-Barr. So the important thing is, if you are suspecting about an acute infection, you should ask for IgM, Epstein-Barr VCA antibodies. And that is why here in color blue, those antibodies are going to be positive from the 4th week up to the 12th week of infection. The treatment, usually patients should have a symptomatic treatment. We can use acetaminophen or any other non-steroidal anti-inflammatory for fever, throat discomfort, or malaise. Also, fluids, nutrition, and low-fat diet, and avoid any sports, especially in the first 3 weeks. The use of corticosteroids is controversial. Sometimes it has been used when we have airway obstruction, breathing dyspnea, but usually we do not recommend the use of steroids for the reduction of pharyngitis symptoms. That is all for today.